Hello, my name is Calum Morrow, and I'm an anaesthetic senior house officer at the Mater Misericordiae University Hospital in Dublin, Ireland. Perioperative bleeding is one of the main drivers of morbidity, length of stay, and cost in cardiac surgery. As the Mater is the National Cardiothoracic Centre, it is imperative that our use of blood products is evidence-based. The aim of this service evaluation was to assess our blood product use in cardiac surgery and the role of rotational thromboelastometry, or ROTEM. Over the last number of years, recent papers have shown that ROTEM testing is associated with reduced transfusion of products. Our aim was threefold. First, to describe how much and what type of blood products we transfuse. Second, to visualise when products are administered relative to ROTEM testing. And third, to identify opportunities to tighten ROTEM guided practice to improve outcomes and stewardship. Our cohort were cardiac surgery patients who required intraoperative cardiopulmonary bypass and had a ROTEM analysed perioperatively. We divide these into three surgical groups: coronary artery bypass graft patients, patients who had valve-only procedures, and patients that had combined CABG and valve procedures. So moving on to the results, this is going to focus on the valve-only cohort. So this cohort required the most amount of blood products and where the most perioperative ROTEMs were performed. So if we look at the table down below, these are cases that received 2 or more blood products. During each case, the blood products have been plasma, fibrinogen, and platelets. So you can see in the valve at the bottom there, 8 out of the 26 cases which required 2 or more blood products, where a ROTEM was drawn in that transfusion window, so that's between the first and the last blood product. So nearly a third of these cases had a ROTEM sampled in that transfusion window. Now looking a bit closer at this group, they had the highest mean and the highest median products used per procedure. So you look at we have the mean table down below, and you can see at the bottom there that the valve for each of our types of blood products is significantly ahead. This is also the case of the median, where on average about 1 extra type of blood product per procedure for the valve group. So interestingly, when we look at in terms of the timing, when each of the first ROTEMs were drawn per group, the valve only was the latest, so 148 minutes after nitroskin compared to 104 minutes for the simple CABG and 77 minutes for the combined CABG and valve cases. They also had the lowest percentage of patients where a pre-cardiopulmonary bypass ROTEM was drawn, so almost like a baseline coagulopathy ROTEM, despite being in this, as we said, the high-risk group. So this graph looks at the timing of blood product administration relative to the last ROTEM being time 0 in the middle. So if we look at each of our rows, we've got platelets along the top, fibrinogen in the middle, and plasma along the bottom, and each of our X's are color-coded as per the procedure. So looking at left of time 0, we can see in fibrinogen and plasma that we've got a huge density of blue X's. So those are valve-only blood products being given there. So we can see that they're given more empirically rather than being ROTEM-driven, being given before that last ROTEM. And then we can see actually when we look right of time 0, we can see all these blood products were given after the last ROTEM was performed. So there wasn't a follow-up ROTEM to ensure this coagulopathy had been correctly treated. So in conclusion, the timing and type of products administered varied significantly per procedure with inconsistent checkpoints for ROTEM sampling. So our recommendation would be an implementation of a standardized protocol for ROTEM analysis and ROTEM-driven coagulopathy management. Thank you.